Okay, good evening, everybody. Let's start with this another session of valvular lesions. I'm sure you're going to get benefited with this. I'm going to show a live demonstration followed by some queries. And at the end, we are going to have an exam on a valvular heart disease, except for a Dhaka people who could not attend the class last time. With this few words, let's start this particular proceeding of 49th comprehensive course on echocardiography. This is the first patient which I'm going to show you. I hope you'll be able to see on the screen this. This is first case of mitral stenosis. All of you will understand in mitral stenosis, the most important thing is as soon as you go on a plaques window, you find a dilated LA, thickened mitral leaflets with doming in diastole. PML may be fixed or mobile. And if you switch on the colors, you find significant amount of turbulence. That's what exactly seen over here. And if I switch off a color and try to measure the mitral valve cusp separation, anything more than 6 is considered as, anything more than 9 is considered as normal, less than 6 is considered as severe mitral stenosis. That's a difference between two cusps of the mitral valve leaflets. Third important point is we always evaluate the aortic valve along with it because mitral and aortic, they go together to a large extent, almost 83%. Alone aortic valve involvement is very rare. And if it do happen, I'm not saying does not happen, but presence of associated lesion further increases your chances of detection of rheumatic heart disease. Short axis view, as far as mitral valve is concerned, stenosis, nothing significant would be seen in that. We went on to do a LV measurements and look at the LV measurement in parasonic short axis view at papillary muscle level. It is 24 and 12. This should not be the ideal view of measuring a mitral valve LV system. The ideal view of measuring LV system is, let me just show you over here. Let me just switch off my colors. Give me a second. Once I switch off my colors, I'm able to see my black and white image. I'm going to stop this image at this point, move it frame to frame to get you a maximum LV dimension size. So this is the maximum LV dimension size. And once we have a maximum LV dimension size, we go to measure. And what exactly we measure? We take a caliper and look at the distance between the posterior wall over here. This is the posterior wall thickness. So this is the posterior wall over here. And this is the interventricular septum. This is 42. And if the body surface area is about 1.7, it will be coming out to 2.25 millimeter or less than 32 millimeter in size. That is the LV dimensions. Because if you have a large LV size, what does it mean by? It's not only associated with severe mitral stenosis or mitral stenosis, there has to be some associated lesion like MR or AR. Let's move on to another factor, same patient. We have to move on to a LA measurements. So I'll get rid of my colors. Here I got my colors. I'll ask the machine to stop my images and then go frame by frame to maximum LA size where the LA, this mitral valve is just close, and go to the measurement, go to the caliper to measure your long AP diameter of my mitral LA. And look, this LA size is almost 47. If the body surface area is 17, it is almost 2.8 or something like that, when it is 2.2 meters, a centimeter per meter body surface area. So very clear about it. We have a dilated LA, we have a thickened mitral leaflet, restriction of anterior AML, posterior leaflet is now. Then what next? Let's move on to the next clips, one by one. We often go in short axis view to look at the pulmonic flow velocity. Look the
One minute.
pulmonic
Posterior leaflet is normal, sir.
thickened and look thickened and just a second. Look at the leaflet. It's not mobile. It's thickened as well as immobile or partially mobile. AML is much bigger than PML. PML will not show some kind of a movement, but it will always show a thickening and less mobility. Can you appreciate the mobility?
Sir, can you say that the posterior leaflet is calcified also?
No, I cannot say a posterior leaflet is calcified, because to have a leaflet calcified, let me
Sir,
show you. I am going to go down my gains to a large extent. Now, you can't see a speckles of calcium in the leaflets. Look what I did.
Okay.
I reduced my gain to a very large extent, the maximum I can do. The echogenicity of interventricular septum, AML and PML, they are more or less the same.
Okay. Thank you.
it is a inverted hockey sign that we say.
Not inverted.
Stick.
This is a hockey shape,
Hockey stick
hockey
sign.
stick sign. This is a hockey stick sign. Why this hockey stick sign is there? Because they are the cords which are attached to the primary, like tip of the leaflets, and the body of the leaflets. The cords which are attached to the tip of the leaflet, they are known as primary cord. The cords attached to the body of the leaflet are known as secondary cords. Right? Whenever the inflammation happens, what will happen finally with these cords? The cord gets cicatrized or thickened or fibrosed. So when the cord becomes fibrosed and small in size, they will not let this leaflet open perfectly. And so these AML becomes hockey shape or hockey stick shape in a normal.
But it is appear just like a cobra hood.
You can say whatever you feel like. What the book says, what is the text says, what is our senior have told, what is our legends in echocardiography has said. They may not have seen the cobra, but everybody has seen a hockey. So in case you want to see, like you see more of a cobra, less of a hockey, then it's more appreciated. So let's move on to the next thing. We always look at a pulmonic valve leaflet, and we look at a continuous wave Doppler across the pulmonic valve. Why we do that? We want to be sure that there's nothing significant in the pulmonic valve leaflets as well. Next answer is, this is just a clip of a 3 dimensions echo. It takes its own time to look at the real thickness. Look, it's not significantly thickened from our point of view, because this image of 3 dimensions echo looks pretty significant if it's really significant. But it tells you a very important phenomena. What that important phenomena is? If I freeze this image and move frame by frame, look, this is the AML out here, correct? This is the PML. AML thickening is more than PML thickening. These are the cord long fibers attached to this AML and PML. The most important part of these cords are when we talk of a subvalvular thickening. Subvalvular thickening means thickening distal to the leaflets of the mitral valve leaflets. Then these cords are thickened. If the cords are thickened and fibrosed, the lesion is not at the valvular lesion, the lesion is subvalvular lesions. In those cases, what will happen? If I calculate a mitral valve area at this point, it will be normal, but the gradients would be high. So this image is telling you, look, the cord involvement is almost negligible. Now, this is a technology what we have been using for a short time. I don't say technology using for long time. This is a biplane or multiplane echocardiography. What this multiplane echocardiography does, it gives you an exact anatomical area of the mitral valve. Take my words, if you have to look at a mitral valve stenosis, what is the best method, dependable method, most reproducible method is multiplane 3 dimensions mitral valve area. What exactly is trying to do? You can see a view where it's cutting at the tip of the mitral valve leaflet. This is not cutting correctly, but this leaflet is off and this is right cutting at the PML level. So this PML is very comfortable, but we are not comfortable with AML level. It has to cut at this level. So we went on to the next frame and now it's trying to cut at the same level. You look at the area 1.8 versus 2.31. And this is what is more important. We have to spend more time in calculating. I'm sure more must be there. Yeah, now look, we are almost at the tip of the mitral valve leaflets. And the calculated area is 1.42. Remember this area? Remember the leaflet cusp separation. That was 0.9 centimeter. Area is 1.42 centimeter square. So we saw 3, this is not correct. We saw 2nd, this is also not correct. The AML is way away. And 3rd is possibly the most correct area. We are just cutting at the tip of the mitral valve leaflet. The area is 1.242 centimeter squares. So one finding was 9 millimeter of mitral valve cusp separation. Second finding of mitral valve area by planimetry 1.42. Let's go further. I'm not going to talk about 4 dimensions echo. The next thing we go to 4-chamber view in mitral stenosis. Look, now you can see very carefully the PML is not moving. Any doubt?
How to
AML
cut in sacks, sir? So sacks we cut, we get, na, sir, planimetry.
Sachs means what?
Short axis view at mitral level, na, sir?
This is
This is
multi-dimension. This is image which is derived from either GE95 or X-plane in Phillips. Yeah, now your question could be a different one. Your question is how to get the best mitral area without this particular facility, correct?
yes.
Okay. If you have to get this without this facility is, concentrate on this slide. What is this? This is papillary muscle over here, correct? This is apex and this is the mitral valve leaflet. Is that correct?
Yes, sir.
Okay. If I go to short axis view at papillary muscles, where I am in this view, I am over here at this level. I'm cutting at this level. What I get? I get a short axis view in parallel short axis view at papillary muscles, correct? If I angulate my probe in such a fashion that I'm going from papillary muscles to the mitral valve leaflet tips. So how will you angulate your probe going from papillary muscles to angulate at the mitral valve leaflet tips? We are in parallel short axis view.
Yes.
So what are the views in parallel short axis? Aorta?
We have to tilt.
Mitral
Wait,
directly.
wait a
Capillary
minute.
and
Wait a minute. All of you are wrong. We go from aorta, then we go to papillary muscles, then we go to mitral valve. No, we go to aorta, mitral valve, papillary muscle, and apex. Correct?
Yes, sir.
So if I look at this view at the papillary muscles, if my footprint start looking towards where?
Sir, directly.
From short axis view, we can go
Yes,
towards.
sir. Directly, sir.
Upward.
Towards तो upward रहेगा, papillary muscle का downward रहेगा, ये directly रहेगा, sir.
अरे मैडम सुन तो लो ना मेरी, एक मिनट सुनोगे तो सही.
Sorry,
सारा
sir.
आप ही पढ़ा दोगे तो फिर मैं क्या करूंगा?
Sorry, sir.
तो आप पढ़ा लो पहले, फिर मैं पढ़ाऊंगा. Whenever you cut short axis view, where do we cut when we bring back from papillary, from plaques window back to parallel short axis view? At what level do we cut? We cut at the level of mitral valve, because mitral valve is at 3rd intercostal space. Then we tilt our probe to right apex to create aorta. Correct?
Yes, sir.
Then we create aorta and then try to bring back my apex. Please silent your mic. Somebody mic is creating a noise. Please silent your mic. This is a very important session. Believe my word, I'll stop it over here. Look, it consumes a lot of energy in teaching these sessions. And it kills my evening practice completely. And you're not uneducated persons. And if I hear a sound now onwards, I'm going to stop these classes completely. If I'm cutting at the papillary muscle level, if I'm at aorta and papillary muscle level, what is the leaflet? What is mitral valve? So we have to go from papillary muscles towards aorta. The first structure we encounter is the mitral valve leaflet tips. parasol short axis view at aorta, go towards papillary muscles, the first structure you will encounter the mitral valve leaflets, which is shown over here in this particular technology by cutting at the tip of the mitral valve. That's how it works. Just write down on a piece of paper, go back tomorrow, go to parasol short axis view at aorta, and then you move your, tilt your footprints from aorta to papillary muscles, means from a right shoulder towards your left hip. As you will tilt from right shoulder towards your left hip, the first thing after aorta will come is a mitral valve leaflet, then will come papillary muscles, and then it will come to LV apex. On the contrary, if you are looking at the papillary muscles, then you go in a reverse direction. From papillary muscles, go towards aorta. From a papillary muscles, go towards aorta, means towards right shoulder. And the first thing you will come across is your mitral. Write down this point and try it tomorrow. So once we look at this view, what exactly is going to happen? Then switch on a colors. Look, these colors are telling you two important things. One is a flame colored, like significant turbulence at the level of mitral valve leaflet, and we have some amount of mitral regurgitation. Look, this is the amount of mitral regurgitation. It could be mild, it could be moderate. I'm not really sure how much it is, but I'll like to say possibly mild to moderate mitral regurgitation is there. But the criteria for mitral regurgitation is not this. Criteria is always vena contracta. Then what we did, we put a continuous wave Doppler across this mitral valve because there was so much of a turbulence was seen. I could keep a pulse wave sample volume across these mitral valve leaflets. Let me try if I could do that. No, you just put a pulse wave over here. Once you will put a pulse wave, you will find a Doppler spectrum pattern with tall E and small, tall E wave, which shows aliasing, significant aliasing. Then you switch over to continuous wave Doppler and then planimeterize this continuous wave Doppler. Look, I'll do a planimetry of this Doppler spectrum pattern. Unfortunately, it's going to do automatically. This machine or software is such that it traces automatically. But let me just do it, calculate by myself. So I'm going to trace this Doppler spectrum pattern. So I'll start with the baseline, go up along with the line, come down, and that gives you heart rate. So my peak velocity is 2.8, mean velocity is 1.72, and look at the maximum gradient is 13 millimeters of mercury. Anything more than 12 is considered as abnormal. Then third point is, let's calculate pressure half time. So I have to go and calculate the pressure half time. Here is a pressure half time. From this point to this point, this is the pressure half time, which gives you an area of 1.6. So till now, we say my gradients are 13, Peak is
So
40.
can you please show that one more time? It was not shown that pressure after everything.
From this point to this point. Peak to the middle of this. So my pressure half time is approximately 154 milliseconds. My mitral valve area is 1.4 to 1.6 centimeters square. Now in this patient, what is the abnormality? If you look at the gradients, gradients are almost 13 millimeters of a gradients. If you look at a mitral curve separation, it's 9 centimeter, 0.9 centimeter. If you calculate mitral area by planimetry is 1.4 to 1.5. And if you happen to calculate by pressure half time, the area is about 1.4 to 1.5. Except for a gradients, everything is matching to a large extent. That area is 1.4 to 1.6. Gradients are only high, and other things are LA is dilated, cusp separation is not. This is a patient whom we like to put, it's not very severe. Very severe would be less than 1 centimeter square. 1 to 1.5 is severe. More than 1.5 is progressive. So this patient belongs to somewhere in the category of severe to progressive mitral stenosis. Now, what next in this patient is required? We went back to do again the same thing. My gradients are now
So
15.
can this patient also have subvalvular stenosis as well?
I showed you there is no thickening of the subvalvular vessels. Now, next is aortic valve. Look at the aortic valve. It has got 3.2 meters of a flow velocity. Peak velocity is 3.2, mean is 2.28. Third important factor is look at the tricuspid and what is the TR jet? TR jet peak velocity is almost 30 millimeters of mercury. And if you look at the criteria for mitral stenosis is you have to have a mean gradient more than 12 to 13 millimeters of mercury, cusp separation more than less than 6 millimeters, then mean gradient more than 12 to 13 millimeters of mercury. Mitral area for a severe or very severe is less than 5 and less than 1 centimeter square. And the peak TR jet velocity or peak pulmonary artery pressure has to be more than 35 millimeters of mercury. Is that clear? So these are the 5 things we always try to evaluate in cases of mitral stenosis. Now the question comes, where do I put this patient? In what category do I put this patient? I'll put this patient somewhere in the category of a severe to progressive, not very severe, 100% is not very severe to progressive mitral stenosis. So let's go to the next, the same patient has got, I showed you the aortic valve flow pattern in this patient. Where is the aortic valve flow pattern? Aortic valve flow pattern is at the level of aorta, which is opened up, and I have got aortic valve velocity inclusive of peak and mean velocity, peak and mean gradient, velocity time integral, and a heart rate. What next I need in this patient? I need to have in this patient is LVOT velocity and LVOT diameter. Let's see whether do we have an LVOT velocity or LVOT diameter in this patient or not. Otherwise, we go to the next subject of aortic stenosis. We are looking at an LV function, which is fairly normal. Yeah, we have got an LVOT VTI. Now take a piece of paper, all of you. Even I'm going to have a piece of paper. First, what we took, let's look at the LVOT VTI. LVOT VTI is 26.71 centimeters. Correct? The next is who is this person who was speaking in between? He was giving prescription to the patient. Can you identify yourself? Dr. Raghavendra? You were speaking in between, right? Dr. Raghavendra, you were speaking or not? At least you can open up your mic and tell me.
Hello, sir. Good evening. No, sir. I was not talking. Sir. I'm traveling, sir. Sir, not talking.
Look, despite all requests, people are speaking in between there with their mic. And nobody would like to, nobody has a guts to say that I was speaking. Be a man, man. If you are speaking, say openly that I was speaking.
Sir, good evening, sir. Sorry, I was not talking. I'm traveling. I was not talking. If I'm talking, I would have told you, sir. I'm sorry.
Please silence your mic. Please silence your mic.
Okay, sir.
My humble request again, please silence your mic because it takes a complete rhythm out of you. So what we were saying is, let's look at the LVOT VTI. It's 26.71 centimeters. And the other VTI was aortic valve VTI. So let's look how much was the aortic valve VTI. So aortic valve VTI is 66.91. Correct? Then peak velocity of 3.02, mean velocity of 2.28, peak gradient of 36.52, mean gradient of 22.7. So can you calculate a dimensionless index from this patient? What is dimensionless index?
LVOT VTI divided by aortic valve
Aortic
VTI.
valve VTI. So let's divide 22.72 from 36.52. What is the value?
1.25.
No, it cannot be 1.2.
0.622.
0.39, sir.
0.39. Okay. 22.72 divided by 36.52 is 0.62.
0.622, sir. 0.622.
So any dimensional index which is less than 0.25 is considered as severe. Very simple
So-
formula at your
Excuse
age.
me, sir.
Yeah.
So you are using a mean gradient,
Yes, sir.
not beating.
Not mean
Sir,
gradient.
it should be. Yes, so
VTI.
you are using you
Sir,
wrongly. Sir,
LVOT VTI is
Sir, it's 26, sir.
26.71.
Sir, using
Okay.
it should be 66.9.
Ek minute. Aortic valve VTI is 66.91, right?
91. Yes, sir.
And what
And
was LVOT
LVOT
VTI?
VTI is
26.71.
26.71.
It's 0.399.
Okay, 0.399. It means like we are way away from 0.25. Correct?
Yes, sir. Yes, sir.
So if it's less than 0.25, then we are comfortable in saying as severe aortic stenosis. That's one parameter. Okay. And if you have to look for a second parameter for aortic valve stenosis, what is the second parameter? What you need now? To calculate continuity equation?
Mean by 14, sir. Gradient, mean gradient.
Now, first calculating of aortic valve area by continuity equation.
LVOT diameter, sir.
LVOT diameter. Perfect. So I have to measure my LVOT diameter, and that's what I'm going to do. Look, my AML right cornic cusp is over here, non-cornic cusp is. This is the one a hinge point. First of all, let me zoom it for you if I can do it. Oh, use you. Okay. So this is one hinge point of the aortic valve. This is the second hinge point of the aortic valve. Correct? Now
Yes,
you know
sir.
how to measure it is 1.6 centimeter square. And do it as many times as possible in mid systole. This is somewhere in later systole. Look at the downstairs. It is somewhere in later systole. If I have to go back and stop this measurements, go back to my image again. Now go to colors, switch off colors, then hold my image. Now my image is roughly at the level of correct. Now I'm at mid systole where the valve was just opened up. Can you see this red point over here?
Yes, sir.
Now I'm going to zoom it up for you. But I can't see a hinge point of this particular leaflet. So I have to move a little bit to look at them. Now I can see the hinge point of this right cornicus. Here is the hinge point. Here is the hinge point of this non-cornicus. So I'm going to measure. That was 1.6 earlier. And this is 1 point over here and another point over here. This is again 1.6. Touch point.
You can go
Sorry.
below, na, sir, 5 millimeter.
Sir, this is LVOT diameter or sir annulus aortic annulus
This
diameter,
is
sir?
aortic annulus diameter,
Annulus.
but we always look what exactly you want to measure LVOT diameter is 2 to 3 millimeter inside. Let me just show how many millimeter. 2 millimeter on this side, 2 millimeter on this side. How cumbersome this process is. Then I'm going to join these lines together. So what's the diameter?
1.6.
It's almost same. So what I do in my practice is I don't look at this LVOT diameter because many people they take it 2 to 5 millimeter inside. But I look at the maximum best hinge point where I can take an LVOT diameter. So we looked at LVOT VTI, we looked at aortic valve VTI, and we look at aortic valve LVOT diameter. Now let me just pick up one person to tell me Dr. Ravi Bala Mahajan would not be the right thing. Dr. Prabhu Dayal Vishwakarma.
Yes, sir.
Dr. Prabhu Dayal, tell me what is the aortic valve area of this patient?
1.6 centimeters square.
Did you calculate it? I'm asking you aortic valve area. Rest of the people can also calculate. Dr. Ravi Mala Mahajan, go ahead and calculate.
Sir, 0.801.
So fast?
सर कर लिया था.
How did you do it, Ravi?
It is 0.8, sir. Sir, pi r square.
Yeah.
Yeah, let her speak, Let her speak now.
Sir, 1.6 divided by 2 gives
8.
us radius into
Point.
3.14 into
Yeah.
r.
No. You made a mistake here only. 0.8 into 0.8, R square.
Yes, sir.
Yeah.
And then 3.14
3.1.
into LVOT VTI
That
divided
is
by aortic wall
Wait a
VTI.
26. LVOT VTI is how much? 26.9.
26.71
71.
divided by aortic wall VTI.
That is 66.
66.91.
So aortic valve area is 0.80. Correct?
Yes, sir.
Everybody
Can you
happy
please
or not?
Yes, sir.
Ravi Bala Mahajan is going to
Done.
explain now to everybody. She is the
Yes.
next teacher to all of us.
Sorry, sir.
Go ahead. Why sorry? Tell everybody how did you do it?
Sir, continuity equation is based on the fact that A1V1 equals to A2V2. मतलब जितना वॉल्यूम LVOT से आएगा उतना ही एओर्टिक वॉल से निकलेगा सर.
Okay, go ahead. Further, next.
तो A1V1 equals to A2V2 तो इसमें सर वैल्यू पुट करेंगे तो हो ही जाएगा ना.
So what she mean to say is whatever the blood which is flowing through LVOT has to flow through aortic valve. It means whatever the blood is flowing over here, it has to flow through the aortic valve. In aortic valve, we have to calculate this area. But here we have an area and here we have a VTI. So here we have a VTI. So if I take this area into VTI and divide by this VTI, I'll get aortic valve area. Is that correct?
Yes sir.
So LVOT diameter was 1.6. You have to calculate area is pi r square. Diameter is 1.6 divided by 2.8. 0.8 into 0.8 is r square. Pi is 3.14. That is pi r square. And if you multiply with LVOT VTI, which was 26.71, so I'll be able to get a volume of blood which is going through LVOT. So can you say how much is the volume of blood which is going through LVOT? 0.8 into 0.8 into 3.14 into
26.71.
0.71. So volume of blood is how much is going through? 0.8 into 0.8.
53.67 sir.
52, approx 50.
No approx. You have to be perfect now. There's nothing like approximate away. You could be pregnant, you could be non-pregnant, but you cannot be mildly pregnant or approximately pregnant.
21.36, sir.
53.
53.67 sir.
53.67.
Correct.
53.65.
That is the amount of blood which is flowing through LVOT with every beat. Correct. Now, this is the flow which is happening at LVOT. Now I have got a LVOT aortic valve VTI. So aortic valve VTI is 66.91. So if I divide this value from 66.91, I'll be getting what is the aortic valve area, and that is 0.80. Everybody clear about this?
No, sir.
Yes, sir.
Please.
Yes.
Yes,
Not,
not
Ravi,
clear.
I
Clear,
request
sir, clear.
everyone to explain.
No, sir.
First
No,
of
not
all,
clear, sir.
First of all, raise your hand who are not clear.
Clear, sir.
So let me look at those people who are very intelligent. Gunjan is not clear. Sachi Surendran is not clear. Who else? Only two.
Not clear, sir.
So 3. Janvi Jayant is not clear. 4. Shripat Kode is not clear.
Clear, sir.
Rest all of you are clear?
Clear,
Yes,
sir.
sir.
Okay, rest all of you are clear. So let me go and explain you with this image in your mind. You'll remember this image or not?
Yes, sir.
Yes, sir,
Okay.
remember.
Yes, sir.
You'll
Yes, sir.
remember this image. Now, I'm stop sharing the image out here. पढ़ते नहीं हो यार आप लोग बिल्कुल भी थोड़ा बहुत भी नहीं.
Yeah, we are clear up to wall area, aortic wall area, but flow how volume.
Equation है ना? ये ना?
तो मेरी आवाज लोगों को बड़ी जोर शोर से आ रही है. Can you see the image?
Yes, sir.
Okay. It's the same image which I showed you a few minutes back. Here is the LVOT diameter. Here is the LVOT VTI. So what does it say? Area at LVOT, the diameter was 1.6. So area at LVOT is pi r square into LVOT VTI or TVI is the same thing. That was 26.71 is equivalent to area of the aortic valve into aortic valve VTI. So whatever the blood of flow which is flowing LVOT has to flow through the aortic valve. Correct? So we have this parameter of LVOT with aortic valve, LVOT area. And we calculated this LVOT area from this hinge point of right cornicus with the non-cornicus that gave us 1.6 at the time. Clear? So I can calculate the area by pi r square multiplied by LVOT VTI, which was 26.71. Either we can do in 3-chamber view or we can do in 5-chamber view. So this is one equation which is ready with us. And this is also known as flow across LVOT or a stroke volume across LVOT. That is what must be confusing.
Yes, sir.
So if I'm looking at the stroke volume, this is what the stroke volume is. What is the blood which is flowing through LVOT is a stroke volume. So this stroke volume is divided by, now on the other side is aortic valve area, which we have to calculate, and aortic valve VTI we have calculated. So what we do, we bring this equation over here so that aortic valve area is this particular segment divided by aortic valve VTI. Is that clear?
Yes. Yes, sir. Clear.
Yes, sir.
No more questions on this?
Sir, just stroke volume. This was up to this was clear. The confusion was at the level of stroke volume, sir. Just
this is stroke volume. So now at the same time, I'll tell you what is another important issue at this time now. Another important issue is, suppose I've got a severe MR. So I'll calculate a stroke volume across LVOT. I'll calculate a stroke volume across mitral valve. If I go to 4-chamber view and calculate the stroke volume across mitral valve and stroke volume, wait a minute. Okay.
That was explained in last lecture also. You have
Correct.
explained that.
I am explaining right now because this will help you in explaining you further also. Now, this is a patient. Suppose this patient has got mitral regurgitation. So we know what is the stroke volume at LVOT. Now in this patient, what I'm going to do is calculate this hinge point and mitral valve diameter. Then put a continuous wave Doppler across it, calculate the VTI of the mitral flow. As we calculate the VTI of the mitral flow in mitral stenosis. So what we'll have? We'll have a mitral valve stroke volume. Correct? So if I've got a significant mitral regurgitation, lot of blood is going from LA to LV, but less amount of blood is going through LVOT. So if this stroke volume at mitral valve is 120 ml and the stroke volume at LVOT is 60 ml, so what is the regurgitation volume?
60 ml.
20 minus 60. So 60 is the large amount of a stroke regurgitation volume. And that equation has found to be very useful equation in day-to-day practice, better than PISA method.
Yes, sir.
And same thing I told you last time. If you look at a mitral valve VTI and you look for LVOT VTI, the ratio of mitral aortic velocity time integral, if it's more than 1.4,
1.3.
that is suggestive of severe mitral regurgitation. Are you clear now how to look for MS, how to look for AS? Little bit of AS, not 100% of AS, little bit of AS. So when we talk of aortic stenosis, what we look at a stroke volume also. So how do we get a stroke volume? Here the mitral stroke volume was 55. How much was the stroke volume?
53.7.
53.
No, we have to be exact. We can't just take out a little bit more. It was, go back. It was 53.65, correct?
Yes, sir. Correct.
Yes, sir.
53.6.
Now I want to index stroke volume. How do you get the index stroke volume? In aortic
Divided by
Divided by 1.7.
no,
Divided by
body-
1.7.
1.75.
divided by body surface area, which could be 1.7. So let's divide by 1.7 this value.
31.56.
31.57.
31.5.
Perfect, 35, 1.56. In aortic stenosis, if you remember, if we talk of a normal flow, the stroke volume was how much?
More than 35 ml.
Perfect. So when we talk of aortic stenosis, we talk of two things. We talk of one is the normal flow high gradient, normal flow low gradient, low flow low gradient paradoxical aortic stenosis. Let me just come down to that slide for you. Now this is what we can get the peak velocity, we can get the mean gradient, we can get the aortic value area, then we can index whatever the aortic value area is divided by body surface area, and then we get index stroke volume. 5 parameters in this aortic stenosis. Correct? So
Yes.
if you where is the stroke volume? This is what the stroke volume is. LVOT diameter giving rise to area multiply LVOT VTI will give you the stroke volume. And index stroke volume, look, it's 35 cc per meter body surface area. Are you clear now with MS and AS? No.
Yes, sir. Yes, sir. But then the AS is severe, sir.
Forget about AS severe or not severe. I'm asking you, can you drive this parameter in your clinical practice or not?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Janvi, Jayant, you still have some
Yes,
question? Your hand is still raised.
Oh, sorry, sir. Sorry, sir.
So let me switch over my gears from MS, AS to some other class.
Yes, sir.
Are we comfortable with this or not? How to calculate? I've showed you demonstration.
Yes, sir. Yes, definitely.
Yes, sir.
Good. For the first time, everybody's voice is silent. Okay, let's move to the next system. When we look for MR and AR, because this is the most common thing which we encounter in day-to-day practice. How to look for MR and AR? I'll first take severe MR because that is what will really have clarity for talking about regurgitant lesions. What is the most common factor for mitral regurgitation? What is the most common thing you see in echo for a severe mitral regurgitation? Anybody?
Dilated LV.
Dilated LV.
Dilated LA.
Dilated LV.
Dilated LV.
It's a dilated LV.
Eh.
Dilated LV would be seen in mitral stenosis and mitral regurgitation both.
Sir,
But it is a combination
winner
of.
contractor.
अरे मेरे भाई पहले मेरी बात तो सुन लो. First foremost thing, if anything has to be said for MR and AR for their severity, when it's severe, is always a dilated LV. Without dilated LV, I cannot say that somebody has got a severe MR or severe AR. Correct. Look at this patient. I have to measure its LV now, size, and that's the index size I'm going to measure. So where I'll go? I'll go to end diastole. Correct. So I'm going to end diastole. And now this is, look at this cursor over here. The red point is at the beginning of systole. So I'm going to measure and I'm going
But
to
we
measure.
don't have the facility of ECG, sir. Then we have to find the closure of both walls, sir.
If you don't have a facility of ECG, means what?
Our machines don't have facility, or our patients do not offer to have chest leads.
Which machine are you using?
G
G what?
जीई के सभी मशीनों में है ईसीजी फैसिलिटी.
You are not using, is that a different thing?
we are not using probably.
No, not we, you.
Yes.
So go back and use your ECG. And I'll tell you very thing honestly. You can use this electrode as many times as possible. 2 to 3 times they are valid.
Okay, okay. Thank you.
Because look, we have to look at the conservative aspect of our country. So this is end-diastolic dimensions of LV, which is 55 centimeters, correct? And I have to divide this by body surface area, and this patient body surface area was only 1.5. So what will be the size? 55 divided by 1.5. It comes out to be 36.66 millimeters. So which is large. For anything more than 32 is considered as large. So once I see a large LV, so I'm quite clear that what exactly I'm looking at. Now look at my LA. LA is little large in 25 millimeters over here also. Then I went to measure other factors. And now this is the machine measured factors is 51 and 50 is endoscopy, 49 is end system, which is not correct. So this is not correct.
Nose, it's the pipe. I have a piece of pipe in my head. Oh, I don't get many visitors. Please sit. Sir, about your accident. Ah, the accident. I really don't remember much about it. We were building a cabana.
This is Dr. Rohan Katta, who was speaking on this mic this time. And Dr. Rohan Katta, please exit yourself. And I'm removing it right now. You can see on my screen. He will not be able to rejoin the meeting again. And all of you are a witness to this particular person. And we'll send a mail to him that he was speaking in between, and that's why he has been removed. Dr. Amandeep Dhanju, please silent your mic. Nikhil Agrawal, Dr. Somnath, please silent your mic. Open when? Only when you need it to. Dr. Somnath. So this is what the size of maximum LV in this patient. Now what else parameter we need in this patient is why we need an MR. If it's MR, what do we see?
Dilated LA.
Dilated LA. Agreed. There could be definitely could be a dilated LA. But the most important thing on this patient is to look for a vena contracta. Look what exactly this vena contracta is. I'm going to get rid of this color first. Give me a second. Actually, let me switch off this colors over here. So I'll take two windows rather than one. important. So same patient, I have to look at the amount of blood flow. No, one window is okay. Let's look good. So one image tells you how much is the vena contracta of this patient. Vena contracta is the amount of blood which is flowing between the two leaflet. Look at the where systole or diastole. When will MR happen?
Systole, sir.
Always
Systole,
Mid
systole.
systole.
So we
Mid.
try to get the best systole in plaques view and then measure the amount of blood which is regurgitating back between these two leaflets. So how do we measure it? Let's go back and measure it. Let's take a caliper. Dimensions, area, volume. The dimensions. So I'm going to take a rough dimension. This is not IVOT. So I'm going to look at this vena contracta from this point to this point. From where it's originating with the tip of the two leaflets. Anything more than 7 is considered as large mitral regurgitation. Correct? Now let's move further. Pulmonic RVOT flow, I'm not bothered. Look at the LV function, which appears to be pretty poor. Avinash Balgi, give me a time, I'll come back to you. Now, this is what you have been practicing in your life for a long time. Everybody teaches you how to look for a jet area versus LA area. So this is a frozen frame of for my second. So how do I look at this jet area versus LA area is, I'll try to measure by caliper area. So this is the area which I'm going to measure is from this point. .1 centimeter. So I'm going to take it again. And here is the LA. So what is the ratio? About 21 and that is 11. So it's more than 50% of the LA area. Correct? Is that right or wrong?
Yes, sir.
11.1 divided by 21, it will come out to be approximately 50%, maybe a little less than 50%, or maybe a little more than this. Let's calculate.
Sir, why?
Let's calculate.
Sir, why that?
Just a minute, I'm coming down. Give me 1 minute. Is about 51.6.
11.1.
No. You have to divide 11.1 from 25. This is 21 is a LA area. Jet area oblique LA area. Not the reverse one. We want to see how much is the area occupied in LA because of LA size. What is the area occupied by MR jet? Correct?
Sir, it is 0.51.
It is 0.5. If you divide by 100%, it will be 51%. Multiply by 100%, it will be 51%. Yeah, go ahead. Your question was there.
Sir, just want to ask, sir, vena contracta and cusp separation, they are one and the same because we are measuring in plaques window both things and severity measurement also is same, sir, for both.
Yeah, vena contracta and cusp separation are two different things. Vena contracta is a jet which is originating between the two cusps. Look, wait a minute, because this is very important. Just give me a second. Let me just shorten this down. Stop sharing. Then slide number 185. Sorry. Now look at this slide very carefully. This is my LV, this is my aorta, this is my LA area, correct? So it has got three parts. One part is through which it's originating. This is known as flow convergence. This is vena contracta and this is jet area.
The flow conversion, PISA, same thing, sir.
Yeah, flow convergence PISA is the same. आप दिल्ली में आ जाओ. I am looking for a person to work along with.
Okay, sir.
बहुत देर बाद समझ आया मैंने क्या बोला.
हाँ सर.
Yeah. Look, this is what is exactly is happening. Lot of blood will flow conversion would be here. Then it will be a vena contracta jet through which is originating, and then this is all jet area. So what you are measuring was jet area. You are measuring at vena contracta through which this jet is originating. If I'll calculate the cusp separation, will not be possible. Why will not be possible? Now think of a winters. If you go to your village used to have a door which has used to have two cusps of a doors. Correct? Balgir?
Yes, sir. Yes,
have
sir.
you ever gone to your
Yes,
village?
sir. Yes, sir.
So the distance between those two doors, when they are closed, they'll not be completely closed. Like long old doors, they become little rounded. So if you try to calculate the cusp area, if you think those doors as a two cusp, you'll be able to see a distance. That is a cusp distance. But the amount of air which flows through those doors during extreme winter is the vena contracta.
Yeah, got it.
Now you got it?
But I thought this means area of the regurgitant jet will be more. That wind, if we are comparing, sorry, sir.
Correct.
But the orifice where we are color that is present in during regurgitation will be same, sir.
The same colors would be there, but those colors you can only measure because that is the hole through which the blood is regurgitating.
Yeah.
And if you want to really see a vena contracta in your life is just take a bucket of water tomorrow, put it in your wash basin.
Yeah.
You will see multiple rings of swirling of water. And that water is going through that drain pipe. That swirling of ring is flow convergence, which is not we calculate a radius for PISA. And through which it's going through is a vena contracta in one section. In today's circumstances, if I have to talk about severe MR in a patient who has got a severe mitral regurgitation, look, I'm not looking at PISA in one of the methods. What I'm looking at this in this fashion. I'll just show you what is exactly happening today in my lab. If I've got a severe MR, now this is a patient who has got a severe MR. Now, this is a very small cut. This is a MR jet over here. So what I did in 3-dimensional echo, I have done a cut at this level. And then look at the cut in short axis view towards me. So this is a vena contracta in 3-dimensional echo, where we take an area. We don't take a vena contracta. Because vena contracta will be only one line or a cut of this section. I'm here calculating the complete vena contracta area. Anything more than 4.4 centimeter is considered as severe.
Yes.
So you are seeing in one slice, and this is what we are seeing in NFS view, the true through which the blood is flowing back into from LV to L. I hope I'm able to make you clear about this.
Yes.
So what we look at jet area versus LA area. We look at vena contracta. We look at a dilated LV. And the another thing which is very important is we look at a regurgitant volumes. How do we look for regurgitant volume? I hope I have done it in this patient. She is Dhanpata, correct. Now, before that regurgitant volume, look what exactly I have done in this patient. I've kept my sample volume right into the pulmonic vein. The jet is so severe that is going all to the roof of the LA. So what will happen to the pulmonic venous flow pattern?
Systolic reversal.
Of everything you will answer, Jan. We let other people talk about it. What will happen, Dr. Baljit?
Systolic reversal, sir.
Where is systolic reversal in this image?
Sir, sir,
How do you identify systolic reversal in this image?
sir, during systole, it should be
So tell me in this image, how do I identify systole?
Sir, from QRS.
Correct.
To
So you look at this, go to just measure. I'll tell you like how to do it. I'll need an M mode caliper. So I'll take a caliper. So this is the beginning of a systole, correct? Can you see my cursors? Is it visible or not?
Yes, sir.
So beginning of a QRS complex to end of a T wave, you see there's no flow. So Dr. Janvi, you have to get your ECG going.
Yes, sir. Yes.
So there is no flow and there is significant truncation of a systolic flow. And if this MR is still more severe, what will happen? You will see a flow downside, as if we showed in hepatic venous reversal. Clear?
Yes.
Let's go to now regurgitant volumes. How do you go for regurgitant volume is we look at this is calculated PISA for you. Let's calculate PISA first. So what did we do in PISA is we went down to our scale. Look, we went down to our scale. Here's a 92, here's a 31. We moved our scale down in the direction of jet. Correct? And then we look at these multiple hemisphere rings. So this is a radius of 0.56 from this peak and to this leaflet tips. And this is all which is required along with MR jet velocity. So MR jet velocity is 5.24 meters per second, 5.24 meters per second. And that was 0.51 if I'm correct.
Sir, when we are reducing the Nyquist limit, na, it both sides it gets reduced.
No. We have to move this Nyquist limit. We don't have to reduce it. We have to move it down. Look,
But for AR, sir, for AR, we have to go upward.
Yeah, we have to go in a reverse direction. So look at this Nyquist limit is 61. So it's 122. 60 plus 60 to 120, 122. And look at this, this is also 122. This is 93, 92 and 31. So it's 123. Hardly make any difference. So the Nyquist limit for aliasing velocity is 31. So aliasing velocity is 31 centimeter per second is aliasing velocity. 5.24 meters is the peak MR jet velocity and 0.56 centimeter is a radius. Do you need anything else in PISA? Let's look at this PISA for a second. I'm going to stop this sharing and I'm going to bring back my images qualities for mitral regurgitation. All right, slide number 104. So let's expand it and share my slides. Can you see my slides now?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So what we are looking at, regurgitant flow is 2 pi r square into velocity of aliasing. So let's calculate regurgitant flow. What was radius? 0.56, correct? This was not diameter, this was radius. So 2 pi r square, first is radius 0.56 into 0.56 into 3.14 into 2, which comes out to be 1.6969. Everybody is done?
Yes, sir.
Multiply by velocity of aliasing. What was the velocity of aliasing? Was
31.
31. So it comes out to regurgitant flow is 61.05 ml. Are we clear about it or not?
Yes,
Yes,
sir.
sir.
Yes, sir.
61.015.
Right. Now we calculate effective regurgitant orifice area by regurgitant flow divided by peak regurgitant flow velocity. This is what we measured over there. That was 5.24 meters. So we divide this value by 5.24 meter, which comes out to be 11.65.
Yes, sir. 11.65.
And if you divide this 11.65 by VTI, so I'll get rid of this image from here. So I'll go back to my original image. You'll remember this flow rate, effective regurgitant orifice area. Effective regurgitant orifice area divided by MR VTI. So only this value of so let me just calculate it again. 0.56 into 0.56 into 3.14 into 2, that was 1.96 into velocity of aliasing, that was 31, 61.05 divided by 5.24, which is 11.65. Is that okay?
Yes, sir.
Now we have to divide by 11.65 by mitral regurgitation VTI. So let's go back to that image again. And let's look what was our is the VTI 15.82. Can you see this screen? No. Hello, everybody. Can you see the screen or not?
Yes,
Yes,
sir.
Yes, sir.
So now the regurgitant VTI is 71.3. So divide this 61, that 11.65 divided by 71. Not 71, sorry, the 132. 130. I'm sorry, 132. So what will be the value now? $11.65 divided by 132. What will be the regurgitant volume?
0.08, sir.
0.08 what?
0.008.
8
Sorry.
ml. So anyway, whatever the values are, there is some calculation mistake somewhere. That is how we calculate it. And most really the calculation mistake lies because what we use centimeter at one point and meter per second at another points. So this was 0.56 into 0.56 into 2 into 3.14. That was pi r square, 2 pi r square into velocity of aliasing was 31, correct? And then we divided by 5.24 multiplied, further divided by 132. So this is the formula, and that's number of times we end up losing our values for calculation of pizza method registration volumes. Now look at the other method, which is very comfortable, which we use in day-to-day practice. We use the method of what is mitral valve dimensions over here. So let's look at this mitral valve dimensions and let's look at the mitral flow VTI. If I calculate mitral valve dimensions over here, annulus dimensions, and then calculate the mitral valve VTI, so it'll give me a stroke volume at this point, correct? At same time, if I calculate my LVOT diameter and calculate my LVOT VTI, it'll give me the flow across mitral valve as well as through LVOT. LVOT flow, if it divided by mitral flow, will give you a regurgitation. Clear? So what all parameters we have seen in mitral regurgitations? Go ahead, ask your question. Don't hesitate.
Sir, last regurgitant flow, LVOT divided by?
Regurgitant flow is whatever the blood which is going from LA to LV, it has to go through LVOT.
Yes.
Is that correct? So if I calculate my stroke volume across mitral valve, how do I calculate? By putting a line measuring the diameter of the mitral valve in 4-chamber. Diameter divided by 2, multiplied by pi r square will give me the, into VTI will give me stroke volume of the mitral valve. Then we calculate the stroke volume at LVOT. Mitral valve stroke volume minus LVOT stroke volume is the regurgitant volume. No or yes?
Yes.
Yes.
Little bit of yes. So what all parameters did you see over here? Dr. Chandrika Nayak. Are you there, Dr. Chandrika?
Yes, sir.
So tell me what all parameter did you see over here?
So 1 minute.
2 minutes granted, not 1, 2.
Actually, the screen got shortened.
Which screen got shorted?
So your screen, by mistake, I don't know what I clicked. I'm not able to.
Okay, you don't have to see on my screen, you know, you have to tell your parameters on your voice only.
1 second, sir.
Shall I give a chance to somebody else?
Yes, sir. I'm not able to expand the screen, sir. Sorry, I'm just trying it.
Okay. Dr. Akshaya Firodia. Akshay, are you there? Muhammad Ali Qasim.
Good night, sir. Sir, I can't got your questions. So can you
My
ask it
question
again?
is, what all parameters did I show you for mitral regurgitation?
I have seen the LV and LA, dilated LV and dilated LA, sir.
Okay. What else?
That.
Batao bhai.
Sir, I can't. Thank you, sir.
Why you can't, man? Are you not listening to me? or you are at practice right now?
No, sir, I'm not practice. I'm sure.
Then are you not listening to me? Not putting up papers? We have discussed this.
Yes, no, I have seen, I have listening you words regarding the flow, regarding volume,
Then
PISA method.
so sure, tell me what all did you learn to? Listen to me. How can you take an exams tomorrow?
Yeah, sir. We have to calculate the PISA method and the regarding volume and also the MR jet area and divided by the LE volume to measure the severity of the MR. And we also have the dilated LA and LV and the systolic reversal of the pulmonary vein.
That's all I'm asking you. I'm not asking more than this, man. That's all I asked you. Okay. All right. So anybody else some question about MR?
Sir, how to adjust the Nyquist limits, sir?
There's a button in your machine to adjust your Nyquist limits. There's a button on a machine on the top of a machines which moves you up and down. If you go, which machine are you using?
Sir, GE. I don't know the model, sir. Full name.
Okay. In G machine in front, there will be a button which talk of a Nyquist limit. One will say of a scale, second will say a baseline.
Yes, sir.
Right in front of you, the knobs are there. Two knobs are there. One will talk of a scale, second will talk with the baseline. You just make the baseline down, the baseline will go up, down. Others say the scale will go down, the both sides scale will go down. Okay?
Yes, sir.
Yes, sir.
Sir, in last MR lecture what that madam has taken, she has mentioned that pulse wave A and E ratio, if the A is more than E, then it cannot be severe MR. That's what that point she has mentioned in the lecture.
What is the point she mentioned? E and A means?
If the A is more than E, then it cannot be severe MR. I think she has mentioned in that lecture. How that point is valuable?
Yes, because E will be the forward velocity, and if it is less than last rapid contraction, then MR cannot be severe because volume will increase, na ejection.
But she has mentioned one point. If that is there, then severe MR is ruled out.
When A is smaller, E is E is smaller, A is taller. That's right.
A is taller.
A is taller because
Sir, if E is more than 1.5 meter per second, then it is severe MR.
That one point.
No,
And
it's not severe MR. It is suggestive of severe MR. Suppose you have got anemia. What will happen to one E wave more than 1.5? It will be there.
Velocities will be more.
Correct. So you cannot depend. That is one of the point to talk about. What
You
she must have
methods.
said is E is smaller, A is taller. When E is small, like whenever the stenotic or registration region is there, what will happen to E wave? It will be a sudden burst of blood from LA to LV. And always the first wave is E wave. If E wave is smaller than A wave, how can be severe regurgitation?
Same CS probe.
Yes.
So whatever the volume of blood which is collected in LA, if you open the mitral valve, it has to rush toward LV. If the initial velocity is only small, there will be no severity of MR. Correct?
Yes.
Same
That's
happens
the
for
point understood.
mitral stenosis also. If the initial velocity is small, then how can be severe mitral stenosis? All right.
It is to rule out the severe MR. Sir. Is it to rule out?
You can create your own formulas, but we do not rule out. We say MR. I'll say that I'll not put my emphasis. I'll not go further. If I see my small e, tall e, I'll stop it over there without going further. Okay, let's go to AR now. This is a patient.
Sir,
Yeah, go ahead. Go ahead.
Sir, for PISA, which view is okay?
Apical
Four
four
chamber,
chamber.
no?
Apical four chamber.
Sir, one more question, sir.
Bolo.
Sir, while calculating jet area, why are you leaving that blue color, sir?
Oh, I was expecting this question from a long time. Can you identify yourself?
Ravi Bala Mahajan, sir.
Ravi Bala Mahajan, I was expecting this question from all of you. I was not leaving out that area. I was saying this area is severe MR. You know, like what you're saying is a little different. I'm not leaving this blue area. You should said I should include this red area also.
Yes, sir, Conda effect.
This is Conda effect. Blood which is regurgitating back into the LA is going back towards the mitral valve in a same cycle.
Yes, sir.
And if you happen to see this Conda effect, it means the MR has to be severe.
Severe. Yes.
Like if you see a tall E, a small a, then chances of MR will be severe. If you happen to see this kind of a Conda effect, it means MR is definitely severe. If I have to really, if I have to really measure this area, after this question, I'll measure this area like this.
Yes, sir.
That was 21. Now it's 18 centimeters. I did not do it deliberately because I thought all of you are in initial phase. You know, I'm sure. Like I really watch for. I'm really telling to Ravi Mala Mahajan, come and join with me.
Yes, sir.
I'm not joking. You will be an asset to our lab.
Thank you, sir.
Just say thank you. You're not coming.
Yes, sir. Try.
Okay. Anyway, just joking about. Okay, fine. Good question. And I was expecting this from one of you. Let's move ahead with aortic regurgitation.
One more ratio, sir, it is mentioned in book. Can I ask?
Which one?
MRZ area versus divided by LVOT ratio. What it means?
MRZ
area divided by LVOT ratio. Some characterized mentions.
My book has mentioned?
Yes, sir.
Just send me a photograph. I'll have to look at it.
Yes. Okay, sir.
Just WhatsApp me the photograph.
And what is standard scale of this color?
Nyquist limit. Nyquist limit. 50 to 60 centimeters.
Okay.
So I'm going to show you next aortic regurgitation.
Yes.
In aortic regurgitation, as we talk of a dilated LV, if it's a severe mitral aortic regurgitation, the LV has to be still dilated. Correct? So what we look at a LV size. I'm not going to measure it further. We do measure LV size. It has measured already over here. So I cannot say it's not large. So let's move further. And now you can see a beautiful two jets, which you can see. One jet you can see. One image over here and second image over here. They are two different images. They are not the same images. So before I measure my images, I have to look at my LVOT diameter. And how do I measure my LVOT diameter? I'm going to stop it for you. Move frame by frame. So go to systole. Now it's gone back. Right. Not a very good images for calculating LVOT diameter. We have to move from one hinge point to another hinge point. Correct. So I'll measure for demonstration purposes, but I'm not happy with this image to measure. So let me measure this LVOT diameter. Correct. Next is I'm going to go to the color images. what do I measure in this color images? I'll stop this color image, then move to the maximum during systole. Systole or diastole? Ravi
Diastole.
Balama. It's diastole. So that was LVOT diameter, which I measured. Now I measure my jet width height at LVOT level. So this is my LVOT level. I'm going to measure my jet width height over here. So I'm going to measure my jet width height at this level of LVOT. So we'll keep on writing. This is 0.7. What was LVOT diameter? Nobody remembers, right?
Centimeters, sir.
2 centimeter. 2 centimeter.
2 centimeter.
20 mm,
20 millimeter, and this is 7
0.7.
millimeter or 0.7. So this is one parameter is jet width height oblique LVOT diameter. Comes out to approximately 33%, right? Is that clear? 7 divided by 20, approximately 33%. Satya is 21. 7 divided by 21 is 33.
Yes, sir.
So about 33%. So 33% does not qualify into severe aortic regurgitation. Now, next point is we have to measure the vena contracta. And this is most important thing in any subject when we measure the vena contracta. And I'm going to stop it over here. And when the vena contracta would be there, diastole or systole? Diastole. So I'm moving my cursor to diastole, and I'm sure Dr. Jayant is going to have an ECG gating tomorrow for me to calculate the vena contracta. So this is in diastole, and this is what the vena contracta, which is originating between the jet of the two leaflets. Look at the Nyquist limit 60. And now I cannot measure it. So what I'm going to do is zoom it up. So I'm going to zoom it up a little. And this is all I have to measure. This is very small, tiny vena contracta arising from here. So I go to caliper and I measure my vena contracta from this point to 0.2, 0.3. And in case you have a difficulty, what you can do is you switch off CFM and then look at the leaflet from where this jet is originating. This off and on system is there in your machines. So you can switch off these colors and see where my leaflets are. And in that fashion, you can look at your vena contracta. Let me just try to do it in colors. So I'm going to switch off my colors over here. I can't see my posterior leaflets. So that will be a difficult thing to tell you. But even one leaflet, I should be able to tell you about. Please stop frame by frame. At least I'm able to see one leaflet. That's one. Here's one leaflet. So this is now a better vena contracta I can see. So I'll measure this vena contracta. That is 0.1. That was 0.2 over there at that time. This could be 0.3. 0.4. 0.3. 0.4. 0.3, 0.4. Somewhere not severe. Anything more than 7 millimeter has to be severe. So one, LV is not dilated. Jet width height oblique LVOT height is only 22 millimeter, only 33%. And the vena contracta is 3 to 4 millimeters. We have to measure this vena contracta as many times as possible. What else you would like to see in this? Pressure half time. How do you see pressure half time? Go to apical window and see the jet of a pressure half time in this fashion over here. So let me see whether we can see a pressure half time in this. I have to put my baseline down. No, not PW. It's a CW again. I don't record pressure half time. So that's why it's not showing a pressure half time. Let me try whether I've recorded or not. Unfortunately, I have not recorded pressure half time. I should be able to record if I'm comfortable. caliper, volumes, area, control. Anyway, pressure half time is the same thing as we do in mitral stenosis. Let me just try to calculate a pressure half time in this. Let me go to one subject, then I'll come back to this patient. Yeah, my other patient has got this pressure half time. So again, this is aortic stenosis with regurgitation. So I'm going to calculate my pressure half time in this patient, which is now over here from this point to this point. And the pressure half time is how much? 847 milliseconds. Correct? And you have to measure in multiple windows. Here the patient is in atrial fibrillation. The pressure half time will be very variable. It's like ranging from 676, 476, 666, 847. So what we do when
Mild.
Mild air.
mild only. What we do in number of time when we have this kind of a pressure half time, in atrial fibrillation, we try to take the longest possible slope as we do in mitral stenosis with atrial fibrillation. So we take the longest possible slope, which is over here, and that's how we take a pressure. Correct? The next point in aortic regurgitation is holodiastolic reversal of flow in descending aorta. Not in this.
It was systolic only. Holodiastolic was not that was.
Holodiastolic. But that is not the place where we look for holodiastolic. We look at the holodiastolic in descending aorta or abdominal aorta. That's what I'm trying to look. Give me a second. I'll try to find it out somewhere. All right. Let me just show from somewhere else. Give me a second. Dr. Ravi Gantoor has come now after 2 hours, after finishing his practice. This is 86. Now look, this is a classical feature of ascending aorta, arch and descending aorta. And you look at this very carefully. If I hold this picture, this is systole beginning and end of a systole. So let me play this picture and hold on for you. Look at this cursor. This cursor is at the level of beginning of. This is blue in color, that is away. And as we go further in this patient, this is all red. Now this is beginning of diastole. This is all red. This is holodiastolic reversal of flow in descending aorta. And if I keep a sample volume in this holodiastolic reversal of flow by pulse wave, not continuous wave, what we see are through and through right holodiastolic reversal of flow in descending. You trace this Doppler spectrum pattern, total 22 and diastolic velocity 22. Then is severe aortic regurgitation. For that matter, what is like in a subject, if has got a severe aortic regurgitation, what is the most clinical sign, important clinical sign?
Wide pulse pressure.
Blood pressure, sir. Blood
Wide
pressure.
pulse pressure. Correct? So what is wide pulse pressure? Rapid runoff.
The
So
diastolic pressure is very low, sir. In case may
zero.
go to zero.
Correct. And we used to remember in our collapsing pulse, we used to raise a hand and check at the collapsing pulses. What was that collapsing
Hammer
pulse?
pulse.
What was that? That was
Rapid fall and rapid high, rise and fall, sir.
correct. So that was a feature of a aortic regurgitation. So that same thing happens when systole happens, blood is pushed forward and rapidly it goes back into the L. So this is how we are looking at aortic regurgitation. Now let me just show this slide, which is very, very important slide. I must have shown it before also. What are the most important factors in calculating the severe aortic regurgitation is LV size. We know how to measure LV size. Second is jet width height oblique LVOT height. I showed you jet width height oblique LVOT height. Pressure half time. I showed you pressure half time. I showed diastolic, holodiastolic reversal of flow in descending aorta. I showed you holodiastolic reversal of flow in descending aorta. Then we showed vena contracta and density of a color flow. I'm not really concerned for the density of color flow. And this is what parameters paper published in 2013 saying that 20 cases were sent to 20 legends in the world who were doing echocardiography to assess the severity of AR in those 20 subjects. What was the common consensus for all of them? LV size or a volume index was mandatory in all cases of aortic regurgitation. Then 2 out of these 3 parameters, vena contracta, holodiastolic reversal of flow in descending aorta, jet width height oblique LVOT height. No pressure half time, nothing that was kept at the time. So if you happen to look at dilated LV size index means like 32 millimeter per meter body surface area. And if you have a vena contractor more than 7, if a holodiastolic reversal of flow 22 and 22, 20 and diastolic velocity 22 centimeters of VTI, or a jet with height of LUT height more than 65%, then you're talking of a severe aortic regurgitation. That's all at your level for aortic regurgitation. Any questions? For AR, we talked about MR, we talked about AR. Now, any question you can raise your hand. Dr. Lalit Bhardwaj, first question.
Sir, can you explain about pressure half time, normal values and abnormal value about
Pressure half time is very simple. Normal values is more than 440, less than 220 is severe.
Thank you, sir.
Mahananda Matre, any question or you silent your mic?
Yeah, Mr.
Any question? No. Anybody else? I'm sure all of Dr. Naveen, go ahead.
Good evening, sir. I have a doubt in the color scaling. There is a green color which is seen in the both end of the spectrum. I mean,
that is variance scale. Variance scale of a color map.
How should we interpret if even in the holodiastolic reversal, I could see the green. So how should we interpret that? Sir?
There is no green color in holodiastolic reversal flow. Look where it is. A minute.
The previous video before the holodiastolic, the scale had the green.
Just a minute. Give me a second. I'll come down to that. You mean to say, just a second, what you mean to say, I'm getting it now. You mean to say this scale?
Yes, sir.
This is known as this is variance map. This variance map is the color are changing on this scale also. Normally you are tuned to red and blue, correct?
Yes,
so
sir.
You remember what is Vibgyor? Violet, indigo, blue, green, yellow, orange, red. So red, violet, indigo, blue, green, yellow, orange, red. That was a Vibgyor. So all 6 colors are seen over here. And this map is known as a variance map. And in your machine, you'll have 3 maps. Normal map, enhanced map, and variance map. Go back, change your map in your machine. Go to the buttons of colors. Change your map to normal, enhanced, and variance map. Variance map gives you a very good color feeling in high velocity jets. I can change this map to other color, other map also. Let me just try that map. Give me a second. So if I'm using some colors, look, this is not variance map. This is enhanced map. Can you see this? Like the colors are changing from red to green, blue to sky blue. And some of the map you will see only red, only blue. Okay, now I'm changing to variance map. Look, there's a button. I change from, first of all, I switched over my map. Now this is, look at this color flow over here. As soon as I change my color to variance map, I could see this same thing, but I could see a better color flow in this. It's all depend what kind of a map you are tuned to. So this is now enhanced color map. I hope I can reduce the scale of this enhanced color map. Look, this is baseline variability. And this is what I may move the baselines going down. So this becomes a Nyquist limit for pizza. So go and play with the machine. The best part of the machine is play with them. And these electronic machine, even if they whatever you switch them on, switch them off, they'll come back to your normal sectors. Normal settings.
Sir, one question, sir.
Go ahead. Any questions? More than
Sir, while calculating the stroke volume across the mitral wall, shall we take the VTI in PW Doppler or CW Doppler, sir?
whatever it is, if there's no aliasing, any one of them would be valid.
Because,
Preferably take it PW or CW, sorry.
because there is gap, protodiastolic gap between E and A. So how will we trace that?
Just come to baseline and trace it up again. Wait a minute.
So show in that graph the calculation of TVI in severe AR, actually show by the cursor. Page number 211 diagram.
Wait a minute. I'm just coming down. Give me a second. Let me just first answer this question. His answer of question is when we have a stroke volume across this mitral valve, normally what happens, E come down to baseline and then A comes up. Correct?
Yes,
That was
sir.
your question.
Yes, sir. Yes.
So normally you have to trace this. If I have to trace this over here, give me a second. I'll trace it for you. So what I'll be doing over there is I'll go up. Come down to baseline. Sorry. Come down to baseline, then go up. Sorry, this will not let you to go up. So I'll do something different. Come down to here to baseline, come like this and go up again to trace your E wave.
Yes, sir. Yes, sir. Thank you, sir.
Okay. And I'll say something different. When you calculating the mitral regurgitation for stroke volume, so what will happen to Doppler flow pattern over here? It will not be the same. You'll never come to baseline. This patient has got some amount of mitral regurgitation, some amount of stenosis. In normal subject, this Doppler spectrum pattern would be looking like this only. It will never come to baseline. If it comes to baseline, neither MS is severe, nor MR is severe. Same thing what somebody said, E is smaller, A is taller. If the Doppler spectrum pattern looks normal, where is the severity of MR and AR, MS and AMR?
Yes, sir.
Okay.
Sir, a question regarding a stenotic lesion, sir.
Go ahead.
Sir, it was regarding whether how will we differentiate by looking at the wall, so whether it is a thickened or it is a calcified wall, sir. Is there some referral point to differentiate this?
Speckles of calcium would be seen in calcified valves. Hyperechoic shadows would be seen in calcified valves.
And when to comment the sclerosed, degenerative, or calcified?
Sclerosed, degenerative, thickening without any hockey shape will be sclerosed, degenerative. Degenerative will come at the age of 55, 60 years. In the rheumatic will come much earlier.
Sir, in aortic valve, sir.
Am I not talking of aortic valve only?
Okay.
So retrograde slow TVI in AR, please show.
I'm trying to do that same thing. Just give me a second. I have opened that file again and I'm just trying to show the TVI in AR. I'm not forgetting what you're asking for.
The long form of TVI is given tissue velocity integral in book.
Yeah,
Yes,
velocity
same.
time integral, tissue velocity integral. Either you get born like normal delivery or have cesarean delivery, or you have a breech delivery. So TVI and VTI, they are normal delivery versus breech delivery.
Okay.
Words. I hope you understand. You start laughing after some time. You take
No, sir. Or not,
So
sir. Both are same thing.
same thing. So now you can see this slide, what she was asking me, correct? Hello. Are you there or you're gone?
Yes, sir, I'm
What?
there.
Wanted to meet how to trace it, correct?
Yes, yes, tracing.
So what you
In
should do,
AR.
yeah, this is holodiastolic reversal of flow in descending aorta. So you should
Yes.
start with this point, trace along with this
Sir,
line.
image not seen.
Image is
Sir,
not
image not seen.
image not seen. Okay. Now you can see the image.
Yes, sir. Same image, huh?
Same image. Now this image, you start from this point, go along with this border, and trace the Doppler spectrum pattern.
Okay. AR Doppler spectrum we have to
This
trace.
is AR Doppler spectrum pattern. This is forward
Okay.
flow in descending
Okay.
aorta. We are not
Yes.
bothered about this flow. We are
Okay,
bothered
that was
about
confusion.
this flow. So what we are talking is, you look at the AR VTI. So this is
Yes.
the AR VTI is how much? This is 1, this is 2. So we have to look at 2. So AR VTI is 26 millimeter, correct?
Yes.
Then you have to look at end diastolic velocity. It is not mentioned end diastolic velocity. Take a line straight up over here. This is almost 22. This is 20. This is 25. This is 4 segments are there. Each segment is 125 millimeters. So this spectrum is close to 50 centimeters. If I draw my line right straight over here, it is about 40% of VTI, 40 millimeters of a VTI. End diastolic velocity and a VTI, that is in a diagnosis, more than 22 millimeters of VTI, more than 22 centimeters, sorry, 22 centimeter of VTI and 22 centimeter of end diastolic velocity is suggestive of severe aortic regurgitation.
So there are two components in that reversal. One is VTI and another is end diastolic.
There is no end diastolic component over here. This is end diastolic component is over here. Don't look at this graph. Don't look at these values. Look at the values over here. You trace this Doppler spectrum pattern. This is 2 number of a Doppler spectrum pattern.
Yes,
so I'm
sir.
tracing this over here. So I have to look at a VTI. This is 26 centimeters. But I have not measured this over here. This has to measure separately.
And that is end diastolic.
End diastolic velocity.
How is the application of end diastolic velocity, sir?
More than 22 centimeters. Remember 22, 22.
Okay. Same.
VTI 22, end diastolic velocity 22.
That is severe AR.
Severe AR. It's here written over here.
So does a severe AR reflect as a functional AS?
Dr. Naveen has asked, does severe AR has got functional AS? Yes. Velocity will be increased, but not the mean gradient.
Okay, so the
And
mean gradient.
majority of AR will have some amount of increased flow velocity across aortic valve. Janvi. Jayant Janvi.
Sir. Another thing is why we say so it is jet width height. Is it not sufficient to say jet width?
Yeah, we can say jet width also, but jet width height means at the level of LVOT, we want to be very specific that we are talking about jet width height, oblique LVOT height. So we are measuring anterior posterior dimensions. That's why you call them a jet width height.
Okay.
Sir, if we are not getting this view, unluckily, then that dimensionless index at the LVOT and aortic wall, that also we can use for the grading of severity?
Dimensionless
Less than
index is
0.25?
meant for aortic stenosis, not for regurgitation.
Okay, okay. That is for aortic stenosis, not for it.
Sir, is this also applicable at the level of aortic wall?
No, it's not available at aortic valve level. It has to be in the descending aorta, thoracic aorta, or abdominal aorta.
Okay.
So you have got an image on the abdominal aorta, same?
I have got image in the abdominal aorta also.
Show, sir, please. Same, it will be.
Here is abdominal aorta. You keep a pulse rate sample volume in abdominal aorta. You get the same Doppler spectrum pattern.
Okay.
The question comes when we have to decide between progressive and a severe, means medical versus interventionals. As soon as you see my vena contractor, which is 0.4, look, half of my things are dead already. On those cases, I have to take all parameters, and ultimately I know the LV is not dilated, my vena contracta is only 0.4, and my jet width height and LVOT height is only 30-40%. So I'll not be spending much time on that patient. If I get a patient where some parameters are positive, look what I showed you parameter earlier when I was talking of MR. MR, my parameters is a variable parameters. Then I really spend time on that patient. And then I move on machines from a lower end machine to higher end machines. Suppose I'm using T9 or S60, I'll move on to E95. Anybody else has some questions now? Shall we stop over here now? I hope everybody must be tired by now.
Not tired, but explained very properly.
The PISA for AR should be in plaques.
PISA for AR would be not in plaques. PISA for AR should be in apical three-chamber. Apical three-chamber. Honestly saying, Janvi, we do not do PISA for AR. I've never done PISA for AR. I hardly do PISA for MR also because I know I'm going to commit a lot of mistakes in that. The calculative variables are so many in that.
Yes.
So I spend time more on my regurgitant volume because what ultimately I'm going to get? I'm going to get my regurgitant volumes.
But that require radius of PISA only, no, sir?
Regurgitant volume, I go for LVOT LVOT stroke volume and mitral valve stroke volume.
Okay. Yes.
Why should I go to PISA?
Hmm.
It
Yes.
is a useful end. Where I'm in doubt, I'll go definitely, but I have to spend time in that.
Yes.
When I can get an answer for rest of the things, PISA, I'm really, truly speaking, like I really avoid PISA because even if one mistake will change my complete equation completely.
Yes. And what about, sir, acute AR, acute MR, like in infective endocarditis or
Acute MR and acute AR, like suppose acute AR is like infective endocarditis. Do I need to do anything? I don't do anything with that. As soon as I see a vegetation, I send my patient for surgery.
Yes.
As soon as I see rupture of sinus of valsalva or rupture of polymuscles, I don't do anything. Immediate send for surgery. Because I know, like whatever I'm seeing, when I can see that mitral valve is prolapsing back all the way into the LA, and we see a ruptured papillary muscle or ruptured cords, then I know, like core of the heart, we are dealing with a severe mitral vegetation. If I see a vegetation, obviously I don't do anything. Send surgery. You can calculate because at that time your LA-LV diameter would be normal. In acute phase, when these people of MR and AR they'll present, they have non-adopted LV-LA.
Yes.
The patient will present with acute LVS.
One more one.
Go ahead, as many questions as possible. You are most welcome to ask anything, Dr. Ripple. I'm only afraid of one thing. Don't create a noise. Don't open your mic unnecessarily. Because that changed my rhythm completely. Ask me as many things as possible. I'm very happy when you ask me so many things. Tell me, Dr. Ripple, go ahead. Dr. Ridhichan Meena has come now, right now, after 2.5 hours. Let me ask him a question. Dr. Ridhichan Meena, are you there? Dr. Ridhichan Meena. Dr. Meena, are you there?
Yes, sir.
When did you join, man?
Sir, good evening.
Pardon?
Sir, voice is not clearly hearing, sir.
My voice is not clear. Your voice is not clear. I said, when did you join, Dr. Reddy? Dr. Ripan, you wanted to ask something? Go ahead. Let's finish off this class. Exam today or not? 10 o'clock onwards.
No, sir.
Today, sir.
Yes, sir.
Yes, sir.
Sir, not today, sir. No, sir, no, sir.
Today, sir.
Let's do one thing. Let's
No,
raise
sir.
your-
Today, sir.
No, sir.
Those people who want an exam today should raise your hands. Let's see how many of you raise your hands. मम्मी का एग्जाम होना है बेटा आज. अभी मम्मी पढ़ा नहीं है पूरा.
Even I am, sir, for today.
So it's a less number of people who says today. Only 1, 2, 3, 4, 5, 6, 1. Samsul Kumar requesting to start meeting questions.
Sir, even I can give today. I can't do that sign of hand.
Okay, okay, fine. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 is Dr. Ripan. Thirteen, 14, 15, 16, 17, 18. Samsul Kumar 18, 19, 20, 21, 22, 23 people out of 63. Ravi Mahala Maj. Okay, total 22 people, 23 people have raised their hands. Great. So, if no exam today, when is the exam?
Tomorrow.
What time?
Not tomorrow, sir.
Not tomorrow. Then what day?
Today only, sir.
Today only.
Today only.
सर आज ही क्लास लिया है आज ही ले लीजिए.
Monday
not
morning,
today, sir,
Sunday morning.
Tomorrow
Next
afternoon you can
Friday.
do it, sir.
Acha, let's talk of can we keep it on Friday before the class?
Yes, sir.
We can do it, sir. We can do it, sir.
Yes, sir.
Yes.
Yes, sir. Yes, sir.
So what we'll
That
do,
will be better, sir.
that'll be great.
Yep.
You know, like we keep a class at about 7 o'clock. So before 7, at 6 to 7, we'll have an exam. 5:30
Okay, sir.
to 6:30.
Yes, sir.
And then
Okay,
we'll have
sir.
systolic and diastolic function together on this coming Friday. That'll be okay for all of you?
Yes, sir.
Yes,
sir,
sir.
Yes, sir.
7 to 8 exam and 8 to 10 class.
8 to 11. Then class would be 8 to 11.
सर 6 बजे तक फ्री
7.
नहीं हो पाते सर.
7 okay, sir.
So 7 to 8
7 से
exams, sir. 7
सर
to 8.
7 to 8 exam.
7 to 8 exams and 8 onward the class.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Class with, sir, systolic and diastolic dysfunction, right?
Both of them would be there on this Friday. We have to finish up in this August to a large extent.
Yes,
So
sir.
coming
So
class
7 to 8
topic.
exam.
Quarter to 7 to quarter to 8 is exam. Then 8 o'clock we start our class.
Yes, sir. Right, sir.
Okay, so take care. All the best. to you
Thank you, sir.
next
Thank
week.
you.
Bye-bye.
Thank you, sir.
Good night, sir.
And
Good night, sir.
Dr. Ravi Mala Majan, my option is always open for you. Okay, bye-bye. Take care.
Good night, sir.
We will consult sir herself when we are in need.
Okay. Now you're not in need. I'm in need. Okay, bye-bye. Take care.
Bye.